I think it's working. Yay! For some reason, my internet wouldn't like connect to be fast enough for me to do the live stream. But here's my video. Okay, so as you can tell, we're going to talk about opioids. And I'm going to try to put this right here so you can take a screenshot or you can do whatever you want. Pause it. I don't care. So you can read it. So here we go. Okay, so there are 3 different types of opioids. And then we've also got some other pain relievers over here. But you see how like we got a dark green and then a lighter green? Hopefully that'll help you out. Okay, so the first section that we're going to talk about, let me see if I can turn it. The first section we're going to talk about are agonist opioids, okay? This includes codeine, hydrocodone, morphine, MS-contin, hydromorphone, oxycodone, oxycontin, mepridine, fentanyl, and then methadone. Okay, methadone is just at the bottom. It's not actually an opioid, but we're going to talk about it in just a second. Okay, so agonist opioids are for moderate to severe pain. These opioids will suppress a cough. So sometimes your patient may be in severe pain, but they're also coughing a lot or whatever. Cough syrups like NyQuil from the drugstore have some type of medicine in there that is a cough suppressant. So adverse effects of agonist opioids include respiratory depression, nausea, vomiting, constipation, bradycardia, flushing, sedation, urinary retention, and then itching. But the itching is an immune response. It doesn't necessarily mean that the patient is allergic to the drug. It's just the body's immune response. So it's not like, you're allergic and you're having an allergic reaction. It's just an immune response. So the drugs specifically, codeine is the only agonist to produce a ceiling effect. So if they take 100 milligrams of codeine, they'll reach this level of pain relief. And if they take more, it'll stop. So like here's the ceiling right here. No matter how much codeine they take, they cannot get above the ceiling. They're only going to get to this level. These down here, there's no ceiling effect, so they can keep on going up. They're going to go past the ceiling. For agonist opioids, there are some contraindications. So since they do cause respiratory depression, you're not going to want to give agonist opioids to people who have severe asthma, who have respiratory insufficiency, who have increased intracranial pressure, if they're morbidly obese, or if they have sleep apnea. Sleep apnea kind of goes hand in hand with morbid obesity, but not all the time, but sometimes they do. If the patient has a paralytic ileus because their GI tract is already sluggish, we don't want to slow it down anymore. And if the patient is pregnant. There are some interactions with agonist opioids. These include alcohol, antihistamines, and CNS depressants. You're already pressing the brakes on the body saying, hey, slow down. So you don't want to slow down the body even more with alcohol or an antihistamine or central nervous system depressant. So those are things that you need to watch out for. Okay, for hydrocodone, it's also called Lortab or Norco. This is a combo drug. It's codeine and acetaminophen. So it's most of the time they're acetaminophen. I think that Miss Rochester said it can't be more than 325 milligrams. And codeine, it just depends. It could be like 5 milligrams or whatever. But it's always going to be like 5 325 or 10 325. They'll always have those numbers together so that you can know how much of that pill is going to be codeine and how much is going to be acetaminophen. This is important because a lot of patients can get acetaminophen toxicity, which we will talk about over here. But that's just something to know. Hydrocodone is codeine and acetaminophen mixed together. It's a combo situation. Then we have morphine. Morphine, a lot of people know what morphine is. It's a painkiller, but we just need to know that it's an agonist opioid. You have MS-contin. So anything that ends in contin, CONTIN, is continuous release. This means it's not for patients that are opioid naive, somebody that's never had any painkillers before. This is for the patient that maybe has had chronic pain for several months or several years. They've tried other things. They've tried other opioids, and they are not getting the relief that they need. So the doctor can prescribe them on this continuous release drug. Most of the time, these are going to be capsules or tablets or whatever that have a special coating on them so that they will go into the body and be slowly released over a period of time. It's not going to all dissolve at once and then bam, you get 100 milligrams of your favorite drug. It's going to be like, here, have a little bit right now. And then 20 minutes later, a little bit more will be released. And then a little bit more released for the next 20 minutes. So that's what it means by continuous release. So you've got this cotton right here and then another cotton down here. That's just something to know about cottons. MS cotton is also very long acting. It acts for 8 to 12 hours. Hydromorphone is also called Dilaudid. This is 7 to 8 times more powerful than morphine. So kind of on this chart, we've got not necessarily weak, but we have the weaker ones up here going down to the really, really strong big guns down here. Remember, methadone is just special, but he's just hanging out down at the bottom. So we've got hydromorphone, again, 7 to 8 times more powerful than morphine. Oxycodone, it's also called Percocet or Oxyr. I don't know how to say that. It's Oxyir, just another brand name. Then you have Oxycontin, remember, continuous relief. It's not for the opioid naive. This one is sustained release, which is kind of this, I mean, I don't know really what the difference between continuous release and sustained release or extended release. They're all kind of synonyms for the same kind of thing. It's sustained release for 12 hours. Another fun thing, similar up here, long acting, 8 to 12 hours. Then you have Mepridine. I'm probably saying that wrong, but I don't really care. The brand name is Demerol. Y'all know how to say that. Adverse effects can be seizures. So for this drug, you're going to want to see if your patient has epilepsy or has a history of seizures. So you're not going to want to give this drug to a patient that has epilepsy. Fun fact. Then you get to fentanyl. This is a drug that's totally in the news these days. People are taking it and they take just a tiny bit, but then they still die. That's because just a tiny bit can make somebody die because it is that strong. It is 100 times more powerful than morphine. It's also called Duragesic. I'm probably saying that wrong, but again, I don't really care. So then you got your small guns down here and you got your big guns down here. So like a water pistol and then, I don't know, an AK-47. I don't know. So that's just your order. And then you have methadone. This is a drug that can help a patient get off of another strong opioid. So if like somebody has a morphine addiction or a hydrocodone addiction, they can start taking methadone as a, I guess you could say a substitute. It'll bind to the same receptors in the body that these drugs bind to, but it's going to have little or no effect. It's not going to produce like a euphoric feeling. So it can help the patient not necessarily become unaddicted, but it can help with like withdrawal. So like if the patient is starting to be like, my body physically needs this, my body physically needs this, they can start taking this. It helps the patient get off of other prescriptions. And the brand name of that is Dolophine, but I've never heard it called that. I've only ever heard it called like methadone. So then we're going to get over to the opioid agonist and antagonist. This means that it binds to the receptor in the brain, but it exerts little action. So this can offer short-term pain control, and there's a lower risk of respiratory depression. Remember, these drugs over here cause respiratory depression. So you're always going to want to know, does my patient have asthma? Do they have respiratory insufficiency? Do they, I don't know, COPD, just another breathing thing that can affect how they can get oxygen. This drug is butorphanol. Probably saying it wrong. I don't care. Stadol is the brand name. That's an agonist antagonist. Then you get down to your antagonist. This occupies all receptor sites. It reverses the adverse effects of respiratory depression. And it's Narcan. You know what Narcan is. Naloxone hydrochloride is for overdoses. So if somebody's having an overdose of one of these, give them Narcan, and it's going to kick off the opioids off of the receptor sites in the brain, and it's going to bind. So it's occupying all of the receptor sites. Remember, these bind to receptor sites and cause an action. These bind to a receptor site, but do not cause an action. And I just now realized I'm flipping off the camera. So oops. And then these will occupy all receptor sites. So it can help reverse the adverse effects of like an overdose. So those are your opioids. We're going to get into other analgesics over here. Let me see if I can kind of bend it a little. Might not work. Okay, so non-opioid would be acetaminophen. This is Tylenol. It inhibits prostaglandin synthesis. I don't know if you're going to be able to see this very well, but maybe so. Can you see that? So acetaminophen, it's for pain and fever. It has little to no anti-inflammatory effects. So somebody's inflamed. If somebody's inflamed, you're not going to give them Tylenol. Pain, fever, it's not an anti-inflammatory. It acts on the hypothalamus in the brain. It's contraindicated in those who have a drug allergy. Obviously, if you have a drug allergy to acetaminophen, you're not going to take it. I always think that's so funny on drug commercials when they say that. Don't take this if you have an allergy to the drug. It's also contraindicated in those who have liver disease because it can be hepatotoxic in like high doses, but we'll talk about that in just a second. It's also contraindicated in the genetic disorder G6PD. I don't really know all of the ins and outs of that, but I do know it's a genetic disorder, and I guess your patient can be tested for that. It's also contraindicated in heavy drinkers who consume a lot of alcohol. There's a list, or there's a chart of like if the patient is a heavy drinker, then their max acetaminophen per day is like 2,000 milligrams, while a healthy adult is 3,000 milligrams a day. But I mean, of course, it's going to depend if they're taking other drugs that may have acetaminophen in there, or if they're like a really, really heavy drinker, it could be a lower number. But just know, contraindicated in those who are heavy drinkers. It is possible to overdose on acetaminophen. Again, the healthy range for an adult is 3,000 milligrams a day. The antidote for acetaminophen poisoning is acetylcysteine, also called Mucomyst. You have to have the patient take Mucomyst 10 hours within the time of overdosing on acetaminophen. And it's something to remember. A nursing implication for acetylcysteine is that it tastes really bad and it smells really bad. So put it in orange juice, mix it with applesauce, tell your patient to hold their nose, do whatever you can to have them take this medicine because it can reverse the effects of the overdose. But I mean, it smells bad, it tastes bad, just get it in their body, make them take it. Adverse effects of acetaminophen can include skin disorders, nausea and vomiting, kidney and liver toxicity, as well as some blood disorders like anemia or different types of anemia. That's pretty much it for acetaminophen. Remember, acetaminophen can be mixed with other drugs. It's a classic for combo things. Let's just throw some acetaminophen in there. It's for pain relief. It's for antipyretics, so they don't have a fever anymore. Hydrocodone, remember, is a combo drug that has acetaminophen in it. So it's important when talking to your patient to know, okay, you're taking this drug. Well, how much acetaminophen is that before we give you acetaminophen over here? Or let me see your cough syrup. Does it have acetaminophen included in it? We need to know how much acetaminophen you're taking each day. I'm saying acetaminophen so many times. Take $1 every time I say it. Whatever. Okay. More analgesics include tramadol hydrochloride. This is called Ultram. Let's see if you can see that. We're in this section right here. See how pretty? It's green. Okay, so tramadol hydrochloride inhibits the reuptake of norepinephrine and serotonin in the brain. So this could be for moderate to severe pain as well as chronic pain. Adverse effects include drowsiness, dizziness, headache, nausea, constipation, and respiratory depression, but the respiratory depression is not as significant or severe as it is over here. I mean, it can still depress the respiratory system, but it's not going to be like, oh, we got to monitor them right now. We need to know if they have asthma. It's not going to be like that. And the brand name of tramadol hydrochloride is Ultram. There we go. Okay, lidocaine. I mean, we know what lidocaine is. This form of lidocaine that we're talking about is going to be a patch. It's lidoderm transdermal. Patch, transdermal, kind of makes sense. The patch would go on your skin. This specifically can be used for shingles. So if they have post-herpetic neuralgia, I think I'm saying that correctly. If they have pain from shingles, I don't know, on their arm, they can have a patch for it and it can help relieve their pain. Adverse effects would include redness or edema at the site of the patch. And so this is the type of thing where you're going to want to have them rotate patch sides. So if it's from their right arm, you're going to put it on their left arm or whatever. Okay, here are some other drugs that can help with neuropathic pain. Let's hope I can say this correctly. Amitriptyline. Maybe I'm saying that right. I don't know. Elavil is the brand name. It's an old antidepressant that is now used for neuropathy from diabetes or circulatory disorders. Then you have gabapentin and pregabalin. Hope I'm saying that right. Neurontin. That's not how you say it. But that's how you spell it right there. I have no clue if I'm saying it right, but I don't really care. And pregabalin is Lyrica. I know how to say that because I've seen the commercials for it. These are anticonvulsants, but they can also be used for neuropathic pain. Okay, the last few that we have right here, we have topical anesthetics. So you have prilocaine and lidocaine. Again, this is a combo drug. There's prilocaine and lidocaine. It's a numbing cream. So like before sometimes doctors will prescribe it and like apply it to a child before they go get an IV, or if they know they're going to have a series of blood draws, they'll apply it, put a little, not a Band-Aid, but like some type of covering on it to help keep it there and not let it evaporate or whatever or rub away, and it can numb the skin so that the child doesn't feel the needle going in for a blood draw or whatever. So it's a numbing cream. The brand name is EMLA. I don't know why it's called that, but EMLA. So combo drug, topical anesthetic. And the last drug we have is lidocaine again. So we have lidocaine over here, lidocaine here, lidocaine here. It's just everywhere. Okay, so lidocaine can be used alone, but it can also be used with epinephrine, so it can kind of be another combo drug. So they will typically use lidocaine and epinephrine, lidocaine for pain relief, and then epinephrine for that bronchoconstriction, so it'll keep that pain relief right there. So on like Dr. Pimple Popper or whatever, she'll apply lidocaine. Like let's say I have a pimple right here on my arm and it's going to really, really hurt because she's got to pop it or whatever. She could inject lidocaine and epinephrine right here. The epinephrine is going to do bronchoconstriction so that the blood flow is going to be slowing down on this area of my arm. And the lidocaine is going to prevent it from hurting. It's going to numb the area. So she puts that in. The lidocaine can't go far because the epinephrine is there. And the epinephrine is also going to help with bleeding, so it's not going to bleed as much because of bronchoconstriction or vasoconstriction. It's vasoconstriction. Whatever, you know what I'm talking about. It's not going to move because things are going to be closed. So the term for that is infiltration, and it can also be used in a nerve block for pain. So like they can completely numb my whole finger by doing a nerve block. They can also use lidocaine para-internally for cardiac dysrhythmias. And the brand name of lidocaine is xylocaine. Isn't that fun to say? So those are the opioids and non-opioid pain relievers that we have for this test. Again, I'm going to bring it a little closer, back up or whatever. You can pause it. You can take a screenshot. Good luck. And over here for your agonists, these are your adverse effects. We went over those. Your contraindications and then interactions. So you have your adverse effects, your contraindications right there, and then your interactions. So main takeaway is know if your patient has respiratory depression, monitor that, and also like talk to them about how much acetaminophen they're taking, because they may not realize that they're taking acetaminophen over here in their hydrochloride and hydrocodone, and then over here as Tylenol, and then there's some that's mixed in with their cough syrup. So they need to know about that stuff to prevent acetaminophen poisoning, which they would take Mucomist for. So I hope this helps, and we're going to go on to the next stuff. Yay!